Well, thank you and good morning. Lovely to be here to talk about the PSA Consensus Statement and how it relates to primary care. And we're going to go through a few things today. Just before I do, I'd just like to make a few general declarations. So I do educational talks for Prostate Cancer UK, although I'm not having any kind of incentive or payment for giving today's talk. I am a co-investigator on what's called the Trial of Randomized Approaches for National Screening for Men, or TRANSFORM, which is funded by Prostate Cancer UK and the NIHR Health Technology Assessment Programme. And I do prostate cancer research, focus on diagnosis and primary care, that is funded by the NIHR, Prostate Cancer UK, and Cancer Research UK. Right, got all those out of the way. So what we're going to talk about today in this session is basically sort of the why. So what's the context for this updated PSA consensus statement? What do the statements actually sort of highlight in terms of areas where there was consensus amongst the panel and areas where there's ongoing disagreement or uncertainty? Who are we talking about when we talk about high-risk men for prostate cancer? And, the how, in primary care, in the NHS, how do we apply the statements that have come out of this consensus process? So first of all, prostate cancer screening and primary care. So what's the context for the PSA consensus statement? So in the UK, we don't currently have a national prostate cancer screening program. And this question has been looked at by the UK National Screening Committee on multiple occasions. The last time they updated their recommendations was late 2020. And the current status is that they don't recommend PSA-based national prostate cancer screening on a regular basis. And the main reasons for that is when they've looked at the existing evidence about PSA-based prostate cancer screening programs, some trials suggest there is some benefit, some trials it's less clear. And the opinion of the National Screening Committee is that this is not something that would be commissioned or paid for by the UK government to roll out across the board for all men. However, there is also what is called the Prostate Cancer Risk Management Program. And this is a separate government document on a separate part of the Health Department of Health. And this relates to the use of PSA for men without symptoms in the NHS. And this document has been around for a number of years now, and it has a few sort of key things that it states. So, the guidance states that men over the age of 50 can come to primary care services and request a PSA test. And there's some background and guidance given for clinicians and summaries for patients available through the Prostate Cancer Risk Management Program, which suggests using a PSA threshold of 3, regardless of age. Although it does highlight that men most likely to benefit from testing are age 50 to 69 years. The other element of the PCRMP is that it's a reactive process at the moment. So it does not advocate that health services or GPs should be going out and actively recommending that men have tests. But if they come and they ask for it, that's when we have conversations about the pros and cons of PSA testing and what it might mean if it generates an abnormal result. And the latest version of this guidance was updated in May 2022. So it does take into account some of the more recent changes in prostate cancer diagnosis in terms of multiparametric MRI coming into standard of care in the NHS, as well as different biopsy approaches. And we'll talk more about those later on today. There are a number of gaps, though, in the PCRMP document. So it doesn't make any recommendations for PSA thresholds for men below the age of 50 or whether they should have the test at all. And we know that whilst it's uncommon for men below 50, it does happen, and particularly in certain groups. And one of those groups is men with strong family histories, but there's no specific recommendations about treating men with strong family history of prostate cancer any differently to anyone else, even though we know they're at higher risk of getting prostate cancer. Another group where there's no specific recommendations for GPs and patients is around what to do for black men. We know that black men are at higher risk of developing prostate cancer. There's a higher risk of prostate cancer mortality in this group, but there's no specific advice about doing anything different for these men. And there's no advice for patients and for clinicians about how often PSA testing should be done. The trials of PSA-based screening programs have used different intervals, some going every 1 to 2 years, sometimes up to 4 or 5 years between tests. And there's no advice for patients or clinicians in this document about how often testing should be done, nor when it should stop. At some point, the likely benefit versus the possible harms is probably going to tip in favor of harm at some point for men. And that might be an individual thing, but there's no guidance at the moment around what we should do there. So that's the kind of current context for the PSA Consensus Statement. And these issues were looked at by a whole panel of men and clinicians, men affected by prostate cancer, people in the community. And there were a number of areas where there were agreement. So one area was that there should be more efforts to raise awareness amongst the higher risk men. So making efforts to make sure that men in the community know what the risk factors for prostate cancer are, and think about whether they might be at high risk, and having those conversations with men and with the healthcare service. There was a consensus from the panel around health services having more proactive discussions with high risk men, and that doesn't have to be only GPs. That can be appropriately trained healthcare staff. But rather than waiting for men to come along and raising the PSA test, maybe health services should start being more proactive in how they're raising awareness and having those conversations with men about the PSA test and about whether they feel like they want to go down that route. It emphasized the need for balanced information for men, and this information needs to be up to date. We know that changes in the way prostate cancer is diagnosed and the way men are investigated once they're referred by their GP has changed recently, and that needs to come into conversations, both from a clinician perspective but also a patient perspective, so people know what the process is, what's going to happen after a PSA test, and what are the potential benefits and also potential harms. There was agreement that how often someone who chooses to have PSA testing has the test should be based on their risk. So there's a big difference between people with family history of prostate cancer and those without, people from Black ethnic backgrounds and those from other backgrounds. And how often you should be tested should be in some way influenced by how high your risk is, rather than just a blanket, everyone has a test every 2 years or 5 years or whatever the current practice is. The PSA Consensus panel was very clear, as is the charity through other means, about there's no added benefit from examining the prostate if the PSA is high. And we know from work that the charity's done and others have done that this puts men off, and a number of men don't want to come forward to even talk about prostate issues because they're concerned about examination, which is becoming less and less used. And this needs to get out there, to know that if there's other reasons to suspect that prostate cancer might be present, like an elevated PSA, that doing a DRE doesn't add anything. And the other thing that the panel was pretty clear on is that if this is going to remain government policy, that this test is available and that it's accessed through primary care, that primary care services should be properly resourced to deliver it. And this has been a point that's been made by GPs as well, to say, well, at the moment, there's no specific resources dedicated to PSA testing or prostate cancer awareness raising. And if primary care is expected to deliver this, then it should be properly resourced. So it can be done. We don't have these issues about men struggling to access testing if they want to, or coming forward to meet their GP or other team members of the primary care team to talk about prostate cancer risk. There are a lot of areas where there remains uncertainty, and the panel couldn't come to agreement on certain issues. So what do we do for men who aren't in the high risk groups? How often should they be tested? What thresholds should be used there? When is the kind of cutoff in terms of when you start PSA testing, when you finish? There's still sort of ongoing discussions about what's the best thing to do for men who don't fall into those high risk groups. Something else that was come up was the BRCA-linked cancers. So there's emerging evidence that men who've got family members who have a BRCA gene mutation and are affected by cancers such as breast cancer or ovarian cancer, whether they should be screened more often or in a different approach, because the evidence suggests they're at higher risk, and particularly with BRCA2. So the panel sort of acknowledged that the emerging evidence is there, but it couldn't come up with a sort of an agreed approach for this group. whilst we sort of said, the testing interval should be based on risk, what the PSA threshold should be for different groups is still an ongoing conversation. So, there's lots of different studies that have tried to find the best way to do this, but there's no sort of clear consensus on what the PSA threshold should be. Should it be affected by age? Should it be affected by ethnicity or family history or other, health issues? To try and make sure that the balance of potential benefits and harms is right. The panel couldn't come to an agreement on whether a second PSA test should be done before a man is referred. So there has been a view that because the PSA test can often be high, but prostate cancer is not actually present, and the high PSA test is driven by something that's happened recently, like having a procedure or having a recent infection, that a second PSA test should be done before a man is referred. The counter argument to that is that if you expect men to have a second test, that increases the chances that they'll get lost in the system, that they won't come back for the second test, that the test might not be that useful in terms of changing the GP's decision making. And there have been other guidance documents that are coming out recently in this space that have actually recommended against repeat PSA testing. But for this panel, there was no consensus on that issue. How often a man should be retested if they decide to have regular PSA tests again is an area of a sort of ongoing conversation, but we don't have a clear guidance on exactly how often that should be done and for which groups of men. And if the National Screening Committee was persuaded to change their minds on prostate cancer screening, what that program should look like ideally, what's the best way to do a national prostate cancer screening program in the UK. Again, there was discussions around that, but no consensus was reached. So that's a summary of what the PSA consensus panel talked about and what we sort of agreed on and not. But obviously one of the key sort of decisions that came out of this, or the key consensus areas, was around higher risk groups, and knowing who they are and trying to engage with those men. So as we've discussed already, men with a family history are at increased risk of prostate cancer. And the risk, it can be 2 to 4 times higher if you've got at least one first-degree relative affected by prostate cancer. So obviously, the more relatives affected, the higher your risk. But it's really important to know, what's my family history and has anyone been affected by prostate cancer, because that can affect your risk. As discussed earlier, close relatives who have been affected by cancers linked with the BRCA mutation, such as breast cancer or ovarian cancer, that might be relevant in terms of assessing a man's risk of prostate cancer, and is another important conversation to have. And as we talked about already, Black men are more likely to get prostate cancer at some point in their lives. And so, that is a group that needs a lot more work to try and improve outcomes for men. So how do we apply the PSA consensus statements? Because, this is intended to try and create a bit of less uncertainty around this area, try and sort of help give guidance to GPs and healthcare service providers and men around, what should be done with the tests we have available at the moment. I think a really key thing is to think, how can it be used to reduce inequalities when it comes to prostate cancer? Because not only do we have, different outcomes from Black men compared to men from other ethnicities, and we know that Black men develop prostate cancer at a younger age and are more likely to present with advanced disease at a younger age. But advanced disease also happens more commonly in men from deprived areas and different geographical regions. And this is data from a few years ago now, but the findings in recent times have sort of been fairly consistent here, that the further north you go in the UK, the higher chances of men having metastatic or disease that spread outside the prostate to other parts of the body when they get diagnosed. So, if you're down in London or in the southeast, the chances are much lower compared to someone who, lives up where I am in the north of England, or even in Scotland and Northern Ireland. And it's not just about deprivation. There also seems to be something about geography. So men from rural areas or coastal areas seem to be more likely to be getting late stage prostate cancer when they get diagnosed. So there's something that's got to be done here to try and address this, and maybe the PSA consensus statements can have some role in that. So, in terms of applying the statements, I guess the key thing, as we've talked about in this talk, is to be able to identify these high risk men. That relies on good GP records, in terms of knowing your patient's ethnic background, understanding your patient's family history, having good processes for identifying these men, so that you can have conversations about their risk of prostate cancer and things like PSA testing to try and help pick the cancer up. Making sure that all staff talking about PSA testing with men have appropriate clinical competence and training and access to resources. So we know that it's not always conversations with GPs around whether to have a PSA test or not. Patients, including men at risk of prostate cancer, will come and have blood tests, very often at their local GP surgery or at their local phlebotomy service. And, someone might raise up, do you want to have a PSA test as well? And that's an opportunity to have those conversations, but it needs to be well informed. The men need to be given, all the relevant information to be able to make that decision before that test is added on to, whatever they've come for their blood test for. Because PSA is the only test that's currently available in primary care to help with prostate cancer detection, and has some known limitations, we need to make sure we're using it in optimal conditions. So we need to make sure there's no infection at the time a PSA test is done. We need to make sure the patients haven't had a recent urological procedure that might affect their PSA levels. And it's also important for clinicians when they're interpreting PSA results to think about factors that can not only push the PSA up artificially, but also push it down. So looking at current medications that patients are receiving and looking at whether that could be influencing the PSA level, and sort of making sure that in interpreting those findings that we're thinking about all the different factors that can affect PSA and trying to use the existing tests we have as best we can. The other really important thing, and it will come up later on in today's conference, is about the current diagnostic pathway. To a lot of the big trials around PSA-based prostate cancer screening were before MRI became standard of care and relied on traditional biopsy methods that carry greater risk of harm and were less accurate than current methods of biopsy. And so that needs to come into the conversations around, what will happen next if a man decides to undergo a PSA test and it happens to be high. So they're informed, but also that having those conversations about the potential risks of harm from testing and being overdiagnosed with low-grade, slow-growing prostate cancer, affected by how accurate the modern tests are, needs to be part of the conversation, and we all need to be aware of what the evidence shows on that front. So, key takeaway messages from this talk, is that, there is a policy document that allows for men 50 and above to come and request PSA testing, but it does have a lot of gaps that makes it hard for patients and clinicians to know what's the best way to do this. And, just creates that uncertainty around how it should be used. This latest PSA Consensus Statement tries to fill some of those gaps, informed by sort of conversations and a process, facilitated to try and sort of get the best sort of agreement that we can in these areas where we can. And the panel, one of the key findings from the panel, that higher risk men, should be the focus of prostate cancer detection and PSA testing, and that a more proactive approach in this group might help reduce inequalities and improve outcomes for men. Thank you for listening.